I'm going to be talking about a couple of things, not just about every week counts actually. I'm going to put it in the context about the Australian Sofer baby bundle that was announced in August of this year, and the e-learning package has just been released on the 15th of August. So I'm going to start off by discussing a patient that I looked after about 3 weeks ago, just to really trigger some thoughts and discussions, and then I'll introduce the Australian Sofer baby bundle, aiming to reduce stillbirth in Australia, and then talking about the Every Week Counts campaign. Just with a show of hands, who's heard of the Australian Sofer baby bundle? Okay, that's great. I'm glad you're all here so I can talk about it. So the patient that we looked after at North Shore was a Mrs. AB. She was a 38-year-old woman in her first pregnancy. She had no significant past medical history. She wasn't on any medications. She was working, lives with a husband, non-smoker, normal BMI, really a low-risk pregnancy. So she had midwifery care at Royal North Shore. She had all her normal antenatal investigations, and her antenatal care was very much uneventful. She did all the right things, came to all the visits. So then she called us at 35 weeks. So of course it's always a Sunday, just after dinner. She calls and says, she calls birth unit and she says, well actually my baby hasn't been moving very much, but otherwise she feels well, what should she do? So our guidelines say that any woman who reports decreased fetal movements or no fetal movements, they should come in. So we said, please come in, we'll see you soon. Then we get another call while she's in the car, being driven in by her husband, that actually she's felt the baby move, she's just going to go home now. So what do you think? Still come in? Yeah, and given that I'm talking about the whole context of stillbirth, we said, you know, that's great that your baby's moving now. Please come to Royal North Shore, even though your baby has been moving. So she comes in, she tells us everything's been going well. The baby's starting to move. Not really sure whether the baby's gone back to normal movements or not, but the baby's certainly moving. We just do some OBS, and then suddenly her blood pressure's 160 on 90, completely asymptomatic. We, of course, want to do a urinalysis, and we see 3 pluses of protein, so now we're getting a little bit freaked out. Her tummy's soft. The symphysiofundal height's 33 centimetres, which is within the realm of normal for a woman who's 35 weeks, the plus or minus 3 centimetres. We do a CTG of the baby, which is completely normal. The bloods get sent off, and by this time it's about 11 o'clock at night, and because we haven't got the bloods back, she kind of wants to go home because she's tired, but the registrar, being one of our, I guess, more cautious registrars, said, maybe you should just stay in with us, given your blood pressure's high, we need to get it down, and we might just want to see what the baby's like. So the following morning, we get some bloods back and we see her platelets are slightly reduced at 100. Her AST is up at 70, but the rest of her bloods are normal. We get her blood pressure under control now because we started labetalol. And then I get a call from the MFM consultant because on Monday, that's my on-call day. So she calls me to say, they've just scanned the baby. The baby's really tiny. It's on the first centile. It only weighs 1900 grams, and the umbilical artery Dopplers show reduced end diastolic flow. So just as a reminder, the umbilical artery should really have like low resistance and should always have forward flow in systole and diastole. And usually what happens, as you can see down below, you have increased resistance first, where you can see this, you can see the peaks go up. So this is in systole and this is diastole. So there's always flow here. But then as you get more increased resistance related to preeclampsia or growth restriction, there's no flow at all, which is absent end diastolic flow, except our patient's got reversed. So actually the blood's going the wrong way around. And the fluid around the baby's lower end of normal. So I'm like, oh, this is a bit weird. She's turned up yesterday with really the only thing is decreased fetal movements, and actually the fetal movements returned to normal. And now it's my job to tell her actually things are not that benign, things are pretty serious. So I go and have a chat with her and say, well, let's just put baby on the trace, on the monitor. And I get a CTG similar to this. So she's not in labour, but we're getting unprovoked decelerations. So then we deliver the baby by elective caesarean section, and we deliver a baby of 1,920 grams. Really long baby, but you can see the baby's head's quite normal size, and you can see that the tummy, there's just really no fat on this baby. The APGARs are pretty good, but the baby goes immediately to the nursery given how little it is. Apart from the normal jaundice and low BSLs, the baby actually does quite well in the nursery and then goes home. So for me, this case really brought home to me about the importance of telling women about decreased fetal movements and the stillbirth risk. It's not just about me or you as GPs not knowing to tell women, but it's really, really important that the women know to call about fetal movements, because this case, I think, is really just a stillbirth saved. And we were just really lucky that she decided to come in. And I'm not sure whether we can always rely on luck. I guess the other question that I was thinking about this woman is that could we have detected this growth-restricted fetus earlier, so at least we could have prepared her, rather than she thinking that we're overreacting and just getting shocked 1 minute after another, just saying, oh, I need to deliver you because this is what's happened to my baby. So this brings me to talk about the Safer Baby Bundle. This is a nationwide initiative, and it's got 5 evidence-based elements to address key areas where, if we can improve practice together, this can reduce the number of stillborn babies in Australia. So the first element is about smoking cessation in pregnancy. The second is about recognition and monitoring of fetal growth restriction. The third element is around decreased fetal movements. The fourth element is about safe side sleeping. And the last element is timing of birth. So this nationwide initiative was initially funded in October 2018, and money was given via NHMRC to, I think, all the eastern sideboard states to roll out this initiative. But at the April of this year, after the inquiry into stillbirths, through the MRFF, the Millennium Research Future Fund, the government gave further funding so that this can be rolled out nationwide. By implementing the Safer Baby Bundle elements of care, the overall goal is to reduce stillbirth from 28 weeks gestation by 20% by 2023. And so that's the goal for Australia. Apart from the 5 bundle elements, it's also equally important that we need to focus on other aspects of best practice, such as continuity of care. Models to all women, especially women at increased risk of stillbirth. And these continuity of care models are things like midwifery continuity of care, but also medical continuity of care models, such as yourselves providing shared care to these women that you'll be also looking after in the postnatal period. If you look around the world in developed countries, the stillbirth rate is around 3.5 per 1,000, and from 2000 to 2015, there's been about a 1.8% average rate reduction. When you look at Australia, our stillbirth rate is 2.7 per 1,000. We are ranked 15th amongst all developed countries, but our average rate reduction has only been 1.4%. So at the moment, Australian stillbirth rates are now 35% higher than the 6 best performing countries, and they all have stillbirth rates less than 2 per 1,000. I guess interestingly enough, they're mostly the Nordic countries. So in Australia, 6 babies are born still every day. That equates to 2,200 stillbirths in Australia every year. We know that over the last 20 years, there's really not been much progress in reducing stillbirth rates at all. We know that less than 20% of stillbirths are related to congenital anomalies, and more than 90% of stillbirths are antepartum fetal events. We also know that 20 to 30% of stillbirths could potentially have been prevented because they're due to substandard care or incorrect management of or not identifying risk factors for stillbirth for these women. We also know that there are bundles of care that can save lives. So care bundles are used frequently to improve health outcomes. They've been used in obstetrics to reduce third and fourth degree tears. There's also sepsis bundles of care and bundles of care used in other aspects in medicine. And they usually contain 3 to 5 evidence-based elements designed to formalise care or reduce the variation in the way we practice. So in the UK, a similar Saving Babies' Lives care bundle was found to result in a 20% reduction in stillbirths in hospitals where they implemented this bundle of care. I mean, I always thought Scotland was part of the UK, but Scotland had a separate Scottish patient safety program, and they were also able to show a similar rate of 19% reduction in stillbirths. In the UK, they were introduced in 2015, so that's why this year we were able to see a reduction in stillbirth rates. So the bundle is going to be a package for all maternity hospitals around Australia, which will be freely available. Each of the elements contain best practice recommendations, implementation tools, how we're going to measure outcomes, also in terms of how we're going to measure compliance with these 5 elements, an educational program for health professionals, including GPs, both e-learning and face-to-face teaching, which are freely available, as well as educational resources for women. So there's the e-learning modules that have just been released last week. And it's available for all health professionals to register. It's fast and easy to register. There's an introduction chapter, 5 interactive learning chapters, and an assessment chapter. At the end of the assessment chapter, then they give you a certificate, so then you can claim your CPD points. And each chapter takes approximately 15 minutes to complete. So at the moment, the e-learning package has been accredited for CPD points with the ACM, RANZCOG and the Australian College of Rural and Remote Medicine. It's going under RACGP accreditation, and we think that we'll get CPD points available for GPs in early 2020. And this is the website for you to register. But if you just Google stillbirth CRE, you'll be able to find the link to register. And you may just want to register now, and when the CPD points become available for the RACGP, they will let you know. So when we look at the first element, reducing smoking in pregnancy, when we surveyed pregnant women, we found that currently less than half of women who are smoking in pregnancy are routinely provided with advice and support on quitting. And 1 in 8 women who are smoking during pregnancy are not receiving any personalised advice and support. We also know that GPs who talk to women, pregnant women, about smoking cessation are more likely to engage with smoking cessations, people like the Quit line, and also Stop Smoking, and they're more likely to do that with a GP talking to them than an obstetrician or other health professionals in the hospital, and that's because of your relationship with women and the community. So I guess this is an area that we are hoping that we can work with GPs to try to reduce smoking in pregnancy. In our area, in the Northern Sydney Local Health District, we do have the lowest smoking rates in New South Wales, which is great. But I guess, I don't know whether you've noticed in your practices that you've started to see increasing rates of smoking, because that's certainly started to become an issue across New South Wales. And New South Wales Health has prioritised smoking cessation in pregnancy as a result. So with smoking in pregnancy, at the moment 1 in 10 pregnant women smoke, with disadvantaged women smoking at rates 3 times higher than other women, and just under 50% of Aboriginal women smoke. So the smoking cessation advice follows the Ask, Advise, Help model adopted by the Cancer Council Australia and Quit Victoria. And at the moment, the recommendation is to have CO carbon monoxide testing at the first antenatal visit and 28-week visit. In New South Wales, although there is blanket recommendations, they will be focusing predominantly on the areas with the highest rates of stillbirth, which also happen to be the lowest socioeconomic areas, and they have the highest rates of smoking, such as Southwest Sydney, Western Sydney, and the Hunter New England local health districts. But all this information is still freely available for all the other areas. Yeah.
What is NRT?
Nicotine replacement therapy. Yeah. So the recommendations are that stop smoking is the best, but NRT is thought to be less worse than smoking. So it's so it's not ideal, but it's thought that NRT is still better than smoking cigarettes. Sorry, patches or gum. Sorry, what's the other one? I don't know what that is. So usually it's patches that we recommend, and we provide that.
I'm a GP environmental specialist. So we recommend the 16-hour to give the fetus a break from nicotine replacement therapy for 8 hours a day. So maybe if they're a high smoker, we probably prescribe a 25 milligram 16-hour patch, and then support the use of fast-acting NRT as well.
Yeah. So there's a carbon monoxide monitor that's available. So I think there's only one brand that's licensed in Australia. At the moment, CO testing is provided free of charge through New South Wales Health if you sign up to the education program, and within the education program they teach you how to use it, but also talk to women about smoking cessation. So I can give you the contact details of the person who's in charge of that, but it's mostly trying to focus on hospitals at the moment. But if you ask for it, they will provide the educational resources for free. Did you want to say something? No? Was there any other questions at the back? No. The next element is about improving detection of fetal growth restriction, because fetal growth restriction is currently missed in most pregnancies, and only about 1/3 of cases are detected prior to birth. What we find is that if you look at the survey, women who are assessed for risk factors for fetal growth restriction, if you look at how often this practice was performed, it was only performed just over in 1/3 of maternity service. Only in just over 1/3 of women. So we know that through the Victorian Perinatal Services Performance Indicators, which was last published last year, it indicated that a high number of severely growth restricted babies, so birth weight less than the 3rd centile, were not born before 40 weeks, as in we didn't pick up these babies. So the data suggested an immediate need for Victorian hospitals to improve methods for identifying as well as managing severe fetal growth restriction. Reductions reductions in adverse outcome associated with fetal growth restriction have been shown with improved risk assessment and antenatal detection combined with careful management and appropriate timing of birth. So we want to improve detection and management of fetal growth restriction, and educational programs for clinicians have been shown to improve the detection and reduce stillbirth rates in the UK. So the element is about risk assessment and surveillance of singleton pregnancies for fetal growth restrictions. So it's about assessing all women for risk factors of fetal growth restriction, and there's also a fetal growth restriction pathway. There's also a video available with the e-learning package to talk about symphysiofundal height assessment. This is more, I guess, more FYI. This is really designed for clinicians in hospitals when we're trying to triage women to work out at what level their risk is for fetal growth restriction, and then planning for ultrasound detection and screening for fetal growth restriction. The next element is about decreased fetal movements. So what we found in the Australian Maternity Services Survey is that just over 1/3 of maternity services are currently providing information about fetal movements at the first antenatal visit. We know that maternal perception of fetal movements starts around the 18 to 20 week mark, but many report about being unclear on what to look for as the pregnancy progresses. There's also many myths about babies running out of room or babies slowing down as the baby gets to term that also need to be addressed and that we need to be educated about. There's been quite a few studies around the world that have identified that there's been an inappropriate response to the maternal perception of decreased fetal movements, and that was a common factor contributing to stillbirths. So currently what we want to do is provide information brochures and advice to all pregnant women about fetal movements by 28-week gestation, and discuss the importance of being aware of decreased fetal movements and report concerns. And it's not so much about the number of movements that's important, it's about the women knowing what is normal for their baby and seeing whether there's a difference or a change in the fetal movements. There's also a care pathway to undertake with further examination once a woman presents with decreased fetal movements. There's also resources that are available for download for women in different languages. The next element is about maternal safe sleeping. Yep. Yeah, so the recommendation is that from 28 weeks, you have another conversation and a reminder about decreased fetal movements so that this information can be handed to women. Yeah, it can be given to women. Yeah, so it's just been brought in it was just, I think, it was first released in August, but the e-learning was only released last week, and all this information has just been released last week. So I don't think many hospitals are actually bringing out this information. Sue?
Say to the woman, if you feel that decreased movement, report it straight away. Don't think, oh, I'm going to see the midwife tomorrow, or I'm going to see the GP tomorrow, I'll tell them tomorrow. No, you attend to it straight away. It's so important, and it makes a big difference.
One other thing, and you're absolutely right, Sue, one of my colleagues said to me, which I thought was great, was you should never go to sleep worried about your fetal movements, and that's what she tells all her women, that they should never go to sleep worried or unsure about fetal movements. If you're unsure, call the hospital, come in, get checked, and then if it's all good, then go home. Yeah.
Is there a reason why it was decided to do from 28 weeks gestation?
Rather than earlier? Yeah. I guess one of the problems is with decreased fetal movements is that there's been quite a lot of interest in the literature about this, and a lot of it starts at 28 weeks. Now that viability is starting to get less and less, now down to 23 weeks, there may be some change, but at the moment, it's really about from 28 weeks to try and make a difference to these babies. I guess one of the problems is also earlier it becomes more and more difficult to work out for women what is normal and what is not.
Only because I did recently have a patient, she actually went to a private specialist, but I heard about it afterwards, but she had a stillbirth at 27 weeks, and she actually said later that she had noticed movements were getting less. So I think, even in that stage, what would we do, would we be doing these umbilical artery Dopplers in those patients? So not that you want to deliver her at 27 weeks.
No, definitely not.
You did lose the baby, so...
I guess this does need to be discussed at the very beginning of the pregnancy, and then we usually repeat it at 28 weeks. I think, a couple of months ago, we had a woman who unfortunately had a stillbirth, and she actually reported decreased fetal movements, but actually she didn't turn up. So she didn't turn up for 3 weeks until her next appointment. So her baby had died at 25 weeks, and she turned up at 28 weeks. So she didn't really not know that it was important to talk about fetal movements or even notice her fetal movements. And so when she was asked, she's like, oh, she doesn't think there was fetal movements. And when she was scanned, we found out actually the baby had died 3 weeks earlier, and she didn't know. Yeah. When we look at maternal safe sleeping position, I guess not that surprisingly, only 18% of women were told to sleep on the side in the 3rd trimester. We know that there's been some Australian studies that showed that side sleeping was resulting in an improved maternal oxygenation saturation, fewer maternal oxygen desaturations, and fewer fetal heart rate decelerations. And so there's also some studies in New Zealand that shows that babies are more likely to be awake when the mother is sleeping on her side compared to sleeping on her back. And so it together suggests that supine sleeping may reduce oxygen delivery to the fetus. And so now the current recommendation is to sleep on the side. So in terms of the evidence, I guess there's been some interest and pushback about this element, because there's actually never been a randomised controlled trial to show that sleeping on the side reduces stillbirth compared to things like SIDS, where there has been trials done. One of the things about this is that clinicians are not happy to recruit women in any study to randomly choose, and then once women know about this, it's easy. They can just go to sleep on their side. And so what we're trying to do is ask women to sleep on their side when baby's inside. If they wake up and they're on their back, we just ask them to go back to sleep on their side, because if you go to sleep on your side, you spend most of your time asleep in that position. We ideally say go on the left side, but some women find it very difficult and uncomfortable to be on the left, and so we don't mind. It's not really an issue, it's left or right, it's just not on your back. The last element is about appropriate timing of birth for women with stillbirth risk factors. At the moment, there's a lack of reliable screening tests to identify babies at particular risks of stillbirth. So what the recommendation is individualised care along with appropriate timing of birth to reduce preventable stillbirths. So the risk factors that increase a woman's risk of stillbirth and requires closer monitoring include BMI, age over 35, smoking in pregnancy, a small baby, primiparity, pre-existing hypertension, pre-existing diabetes, IVF or ICSI, preeclampsia, previous stillbirth and multiple pregnancy. And I guess these risk factors for stillbirth don't really surprise anyone in the room. The benefits, though, of planned birth must be carefully weighed against the risks of the intervention, because some of the consequences of planned birth may not be apparent until later in childhood. And so this brings me to the Every Week campaign, Every Week Counts campaign, and I'll talk about it a little bit more later on. So the aim of the Safer Baby Bundle is that it's been developed last year and this year. We're implementing it at the end of this year and next year, and then we'll evaluate it between 2020 and 24. There's been new practice guidelines and position statements, along with a guidebook and the e-learning resources that were launched last week. And implementation will be occurring through all states and territories, health departments, and their associated health improvement agencies. So through New South Wales will be the CEC, the Clinical Excellence Commission. There'll also be a clinician awareness campaign that will be launched next month to encourage all health professionals to enrol and complete the e-learning module. There'll also be face-to-face workshops if required and requested. There's also going to be a new public health campaign, awareness campaign, that will be planned for next year to target high-risk cohorts of pregnant women, as well as a generalist campaign, especially about safe side sleeping and smoking cessation. So the Stillbirth Centre of Research Excellence is based in Queensland, and they're going to be doing most of the evaluation for the Stillbirth Safer Baby Bundle rollout in Australia. So the Safer Baby Bundle has been endorsed by a whole lot of different organisations. The main organisations for New South Wales will be the New South Wales Clinical Excellence Commission, also the Perinatal Society of Australia and New Zealand, RANZCOG, Stillbirth Foundation, Still Aware and SANS, and they are the consumer partners in this rollout. Okay. Any questions before I go on and talk about the Every Week Counts campaign? Okay. So our research group developed this campaign called Every Week Counts. And the background to this is that we know that across New South Wales, the median time at which babies are born has changed from 40 weeks, and now it's down to 39 weeks. But I guess what's really interesting is that it's this cohort around here, the 35, 36 and 37 weeks, that has also increased. If you look at the Northern Sydney Local Health District, just like all the other LHDs, we've also seen a left shift in the median time at which babies are born. We also know that if you look at severe neonatal morbidity, that severe neonatal morbidity reduces as you get closer to 40 weeks. So the lowest risk of neonatal morbidity is at 40 weeks, and then this actually goes up a little bit. We also know that with brain development, a baby's brain at 35 weeks weighs only 2/3 of what it will weigh at 39 to 40 weeks. So there's a lot of brain development going in the late preterm and early term stages. We also know that late preterm infants have less developed myelination and more immature gyral folding of the brain, and both myelination and gyral folding are thought to be important processes in early brain development. So the research group down in Melbourne put all these late preterm and early term babies through MRIs. I'm not really sure how they got consent for it, but they did this. And this is how we know that there are brain changes in these babies. And so if you look at what's driving this increase in late preterm and early term birth, it's really people like Talat and me. It's obstetricians. We're the ones who are driving this early term birth. So one of the reasons why we're wanting to deliver these babies is because we're worried about stillbirth. And if you look at stillbirth rates though, there's been not much change at all in the last 20 years with stillbirth. and yet we're trying to deliver all these babies earlier, and we're potentially causing harm to these babies. So we're worried, as obstetricians, we're worried about being blamed, we're worried about adverse events, and of course we're worried about litigation. If you look at women, we did a survey to look at women's perceptions and beliefs about when is it safe to deliver your baby, and certainly there's a thought that, you know, half of women think, just under half of women think that early term is considered actually full term, and also the earliest safe time to have give birth can be as early as 34 to 36 weeks. So our question was, is it possible to safely reverse the trend towards earlier birth? And you know, the emphasis is really about doing this safely, identify the babies that are high risk of stillbirth and they need to be born early, but if they don't have these risk factors, then deliver them at the right time. So our message with this campaign is that every week of pregnancy counts. It's an educational support that's designed to see whether pregnancy can be safely extended, and it's giving brochures to clinicians to help guide conversations about the timing of planned birth. So there's a website that's freely available with information about this campaign, and that's been rolled out this year. We're going to formally evaluate this campaign in 4 LHDs across New South Wales, because we want to make sure that if we are extending the gestation at which babies are born, that we're not resulting in increased risks of adverse outcomes to babies such as stillbirth. We're collecting outcomes before and after bringing these educational brochures using routinely collected data. So we have the perinatal data collection where every single birth is collected around the state, and we can look at outcomes with this data. So no extra information needs to be collected. So this is the brochure that we provide to women. It's actually more of a pull-out brochure, and there's some brochures available outside. And so it's showing women that across from 35 to term, that baby's brain's developing, also the risk of the baby going to the nursery for certain morbidities such as jaundice, respiratory distress, low sugars reduce as you get closer to term, and also that the risk of learning difficulties at school age is reduced as you get closer to term. So that's based on some evidence that some work that we did looking at the AEDC, which is Australian Educational Data Collection. So in kindergarten, kindergarten teachers need to fill out information about their kids, and then also looking at NAPLAN results. We can look at NAPLAN results and we can link them to the timing at which babies are born, and there's increased risks of babies with adverse, with learning difficulties such as needing extra help in the classroom the earlier babies are born. This is information that we give to clinicians that they may choose to use if women want absolute numbers, looking at infant morbidity and mortality, admissions to the nursery, and neurodevelopmental outcomes for babies born between 35 to 39 weeks. So this is a research group who's been involved in doing all the background work to this brochure. And I'd like to end with a little plug. We are running a Pregnancy and Beyond public forum on Wednesday the 18th of December, talking about long-term outcomes for babies born early, as well as the first 2,000 days New South Wales health policy that has launched this year, talking about from conception to age 5 and the importance of the first 2,000 days of a child's life. And you're all very welcome to come. Yes?
What about after 41 weeks, like 41 to 42?
Yes, there is. So I guess we've had quite a bit of pushback from certain groups because sometimes the information with absolute numbers that people look at and they don't necessarily like to see the information that's out there, but certainly adverse outcomes do start to increase from 41 weeks, but the absolute numbers are low. So I guess it still is a conversation with women about what they want and their preferences, because there will still be women, and the current New South Wales Health Guideline recommends induction for post-term pregnancies from 40 plus 10, so 41 plus 3 weeks, because the uptick is still absolute numbers are low. But I guess when you start looking at this data and you look at what private obstetricians are doing, they're talking about, delivering women by 40 weeks to reduce that uptick after that. The other issue related to that is the ARRIVE trial. I'm not sure whether many of you have heard about the trial. It's a big trial that was published in the US. And what that trial was to look at low-risk women, whether if you induce them by 40 weeks or if you just wait and see whether they go into spontaneous labour or deliver them by 42 weeks, whether it would reduce stillbirth rates. It was a large trial with over 3,000 women, and it did not show a difference in stillbirth rates, but what it did show is that if you induce women by 40 weeks for these low-risk women, it reduced the risk that they would end up with a caesarean section. So it's provoked a lot of controversy in the obstetric and midwifery world with this study. So, yeah. So that's been, I guess, another development, and that was published, I think, end of last year or this year? Maybe last year. Last year, yeah.
Did that trial take into account outright the cervix rolls? Because my experience is that you can cause a lot of problems if you induce a woman too early with an unripe cervix.
I would totally agree with you. If you induce women with an unripe cervix, it's more difficult to get them into labour, and the chance they end up with a caesarean section is much higher. What I found interesting about this study, they did look at it, but they didn't necessarily report the Bishop score of the cervix. But if you look at the median time at which women who were in the expectant management group, they were actually only about 4 days later than the women who were being induced. So, we know that if you go into spontaneous labour, your chance of having a caesarean section or an adverse event is much lower. You're more likely to have a spontaneous labour. It's just that I can't predict who's likely to have a spontaneous labour. And I guess that's, the million-dollar question of obstetrics, how to predict whether you're going to go into spontaneous labour or not. Yeah. Any questions? Or have I provoked more confusion?
Tanya, can I ask?
Yeah.
So part of the pushback around the sleeping position
Yes.
has been that because there's not robust evidence at
Yes.
this point, if someone has a stillbirth, is that mother going to feel guilty that she didn't lie on her back? So what are your thoughts about that?
So I think it's really important that there's no blame, because one of the questions about this safe side sleeping is the baby little, therefore the mother finds it comfortable to lie on the back, rather than actually lying on your back causes the stillbirth. And so I think that distinction does need to be made, but it's very much about the encouragement of women to go to sleep on their side, and if they wake up on the back, they haven't harmed their child, they don't need to be checked, but just go back to sleep on their side. Yeah. Yeah, I mean, in pregnancy it's so easy for women to feel guilty about so many different things, and there's a lot of conflicting information even within the professional side of things. It can definitely be really confusing for women, and that's partly why we've got the Still Aware and the Stillbirth Foundation who are involved, because we want to make sure that this is supporting and also supporting women, especially women who've already had a stillbirth. Yeah.
Low detection rate of the fetal uterine growth restriction.
Yes.
We compared our numbers with the Asian countries. Because in Asia, I find that a lot of people do go to private obstetrician and they get scanned like every month.
Yes.
You get Asian patients coming and ask me, should I go and pay and have another scan? And I've been telling them, save your money, no point. So should I be saying that maybe they should have another scan?
So that's a really good point. Should women be having extra scans? So the only data that we have that I'm aware of at the moment is that there was a study done, should we just scan everyone at 36 weeks to improve detection of fetal growth restriction and other anomalies of the baby. And unfortunately it didn't show any improvements in the babies, and so that's why we don't routinely scan everyone. I guess one of the problems with scanning all the time is that then you can just start intervening unnecessarily, and so that's why there's still an emphasis on identification of risk factors for fetal growth restriction. Though I would want to point out that if you look at the risk factors, especially in our Northern Sydney area, sorry if I just go back. Like a lot of our women are over 35. A lot of our women have IVF. A lot of them are first-time mums. So maybe we should be spending more time evaluating these women, and maybe we should be scanning. And I'm just posing that as a question. I'm not necessarily saying this is even what we do at North Shore, but we should probably think about it in a more considered approach rather than a blanket, let's just scan everybody. Because the other problem is that who's going to be able to afford scanning? Talat, did you want to say something about that?
That's exactly what.
So I think it's very much individualisation. Yes?
Your case that you presented.
Yes.
Is looking at the risk factors, the only one that lady had was maternal
Age and primiparity. Yeah.
Do you work out why in these cases she had the growth restriction? Because age in and of itself, how does that confer an increased risk? Like, is there something to do with the arterial elasticity, or why is age a risk?
I'm not really sure. I'm not aware of the understanding or the biological basis on which age is a risk factor, but there does seem to be some association with stillbirth and age, and that the older you are, the higher the risk. So there is something related to age, but I'm not really aware what. So we couldn't find out why. I mean, the placenta was sent off. The NICU always like to do a torch screen, and that was all normal. And I mean, this baby looked growth restricted. It was a normal sized head, and the baby was skinny and long. That typical growth restricted old woman. I don't know. Yeah, old person appearance. But we couldn't find out why. And in the late fetal growth restriction, most of the time you can't find a cause, and it's presumed to be placental, rather than the early fetal growth restriction. Yes, question at the back?
I'm not sure exactly what they are doing, but some of the ultrasonographers at the 12 to 14 growth scan are putting a whole video about the umbilical artery and Dr. something, an index that they're doing. And I was wondering if that is significant, because one of my patients had that, and then she went to the ultrasonographer, and they strongly suggested that she should be on aspirin. So is this something that we should now be seriously doing, 12 to 14 week scans, looking for these abnormalities in the umbilical artery and thinking of giving women aspirin?
So at the moment, Sydney Ultrasound for Women, I think, and Ultrasound Care, they do screening for preeclampsia at that 12 to 14 week mark, where they do bloods, and then they screen if you have high risk or low risk of preeclampsia. A lot of that is based on actual history of the woman and the background history, and then we recommend low dose aspirin for those women who are at high risk of preeclampsia. The other thing they do is often at the 18-week mark. I didn't realise they did it at that early at Newcall, but at the 18-week mark they do maternal uterine artery Dopplers, so they check the mum's uterine arteries to look for notching. That is a soft marker of also adverse outcome in the future, and they may put them on aspirin at that stage as well. Yeah, so that's been done, but I didn't realise they were doing as early as 12 to 14 weeks with maternal uterine arteries. Yeah. Was there another question?
Any other
Questions?
Thank you, Tanya.
Okay.
That was a great
Thank you.
talk.